In this video we discuss tips on a fungal endophthalmitis case. In this video, shared by Dr. Masoud Mirghorbani from Tehran, Iran, we present a case of suspected fungal endophthalmitis in a patient who developed bilateral uveitis 2 months after cholecystectomy. Given the high clinical suspicion, imaging evidence of persistent posterior hyaloid adhesion, and the risk of future membrane formation, the patient was scheduled for pars plana vitrectomy with diagnostic sampling. At the start, the inflow is turned off to perform a dry tap, and approximately 0.5 cubic centimeters of undiluted vitreous is collected for microbiologic analysis. The inflow is then turned on to obtain diluted vitreous sampling over the lesions. Inferiorly, there is a diffuse chorioretinitis plaque with necrotic areas. When working near necrotic lesions, use low aspiration and the highest available cut rate. Triamcinolone is injected to visualize and induce a PVD, but a complete PVD is intentionally avoided immediately after the initial macular detachment to reduce the risk of iatrogenic breaks. Vitrectomy proceeds to separate the vitreous from the posterior pole and around the chorioretinitis lesions, with care to minimize traction and avoid direct pressure on the inflamed retina. The peripheral vitreous is left largely undisturbed for the same reason. After careful debulking around the necrotic foci, a partial fluid-aire exchange is performed. Before trocar removal, intravitreal voriconazole, vancomycin, and ceftazidime are administered. No sutures are required and there is no wound leak, with a stable IOP at the end. Although smear and culture are negative, PCR returns positive for Candida spp, and the patient is treated with intravenous and prolonged oral antifungal therapy for at least 3 months, achieving significant visual recovery.